Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session.
Good afternoon, everyone. This afternoon's data linkage session is sponsored by long-term NATO partner OnPoint Health Data. As leaders in the health data space, both NATO and OnPoint recognize the importance of linking data from multiple sources, including non-claims data, to support healthcare initiatives being undertaken by APAC-Death, such as the measurement of clinical performance and patient health outcomes. We are excited to share the approaches being taken by the session's presenters and look forward to exploring this important topic together. And with that, I'm going to welcome to our moderator today and organizer, Kenley Money from ACHI, the Arkansas Center for Health Improvement. How are you doing today?
I'm doing well. Thank you, Norm. I'm ready.
All right. Well, the time is yours.
All right. Good afternoon, everyone. Again, my name is Kenley Money. I'm with the Arkansas Center for Health Improvement, ACHI for short, and I am the Arkansas APAC-Death Director. The Arkansas APAC-Death is part of the Arkansas Healthcare Transparency Initiative. And I've been given the pleasure of kicking off today's session called Data Linkages, which is par for the course today. Lots of topics on data linkages. Today's session, 3 videos will be presented, and each presenter will be online and available for questions at the end of their video. Audience members should put their questions in the chat. This is old news now. We've been here for a couple of days. As moderator, I'll read the questions to the speakers during the Q&A time after each session. And after all the sessions are done, there'll be additional time for questions. I may call on the person asking the question to speak if need be, but so far the questions have been very, very easy to manage in the chat. Without any further ado, I'm going to go to the first speaker, who is Victoria Udalova, my apologies, whose topic is Enhancing Health Data at the U.S. Census Bureau, the case of Utah's Emergency Department encounter data. Norm, would you kick off the video? And Victoria will take it from here.
Hello, everyone. My name is Victoria Udalova. I'm a senior economist and the manager of the Enhancing Health Data, or eHealth, program at the U.S. Census Bureau. And today I'm happy to talk to you about enhancing health data at the U.S. Census Bureau, the case of Utah's Emergency Department encounter data. Before I begin, while it's just me presenting to you today, I'd like to acknowledge enormous contributions by my co-authors on this project, but also other colleagues and the leadership team at the U.S. Census Bureau, Utah Department of Health, and the National Center for Health Statistics. Enhancing Health Data, or eHealth, is the research program at the U.S. Census Bureau that identifies opportunities to enhance health records with existing survey and administrative records data that are already available at the U.S. Census Bureau. Our team links multiple data sources to create new data products and conduct research aimed at improving measurement of patient and provider characteristics. The Census Bureau already has data on multiple elements that commonly lack in health records, such as race and ethnicity, education and employment, income and household composition, disability, housing, public program participation, and transportation. For some background on the project I'm about to present to you, in 2019, the U.S. Census Bureau entered into a partnership agreement with the Utah Department of Health, and we had 2 aims. Aim 1 was to examine social determinants of emergency department utilization in Utah in order to reduce preventable visits. While aim 2 was to evaluate the utility of emergency department encounter data for surveys for which the Census Bureau collects data by making comparisons to the National Hospital Ambulatory Medical Care Survey, or HAMSIS. We take confidentiality very seriously at the Census Bureau. Confidential data cannot be disclosed or published in any way that permits identification of a particular person or an entity. Only a limited number of census analysts were authorized to access the confidential data used in this project. And the record linkage identifiers that we used do not contain any health information or direct identifiers. All the output that I'm presenting to you today was reviewed and improved by the Census Bureau's Disclosure Review Board. So let's start with aim 1, social determinants of emergency department utilization in Utah. Our research question was, which individual and household level social determinants of health are significantly associated with preventable ED visits in Utah? We had 2 data sources. One we received from Utah Department of Health, and it was a universe of all emergency encounters in the state during the 5-year period from 2013 to 2017. From the Census Bureau, we had the American Community Survey, which is our largest household survey and captures about 1 to 2% of the US population. And we had it from 2013 to 2017. The most innovative part of this project is the ability to link the 2 data sources at the individual level. We'll link emergency department visit data to the person level and household level data from the American Community Survey. And we did it by relying on the internal person level linkage keys that are available at the US Census Bureau. Those linkage keys, those anonymized linkage keys, are called protected identification keys, or PICs. Once the data was linked, we then classified all emergency department visits. Specifically, we applied the NYU ED algorithm, which is a commonly used method to characterize visits based on their preventability. And we used patient visits primary diagnosis to do that. About half of all emergency department visits in our data could be classified using this algorithm. These emergency department visits were then classified into 4 categories: care needed but preventable, primary care treatable, non-emergent, and care needed non-preventable. The first 3 categories comprise preventable emergency care, which is the focus of our study. In terms of social determinants of health, we had 5 domains, and we have selected 19 specific variables from the ACS data, and they fell into the 5 buckets. We had economic stability, education, social and community context, health and healthcare, neighborhood and built environment, and examples of those characteristics are employment, education, income, health insurance status, access to a vehicle, or access to internet. I will show you some results, and it's just a preview. There is a lot more in our research paper. The graphs are going to be similar, so let me just explain this one in a greater detail. On the y-axis, what you see here is the average number of preventable emergency care visits per 1,000 people. On the x-axis, you see various categories for a given social determinant of health. In this particular graph, we are looking at household income. And what we find is individuals living in lower income households had more preventable emergency care visits. You can see there was a clear income gradient when it comes to income. We find something very similar when we look at educational attainment. We find that lower educational attainment is associated with more preventable emergency care visits. When we look at household size, we find that the individuals who live in smaller households, in particular those who live alone, tend to use emergency department for preventable reasons more frequently. We also look at health insurance, and we find that individuals without health insurance are more likely to receive care from emergency departments for preventable reasons. We can also do the same by looking at employment status. We find that unemployed individuals are more likely to visit emergency departments for preventable care relative to those who are employed. When we look at access to a vehicle, we find that those without access to a vehicle were more likely to rely on emergency departments for their preventable care. And finally, when we look at internet access, the story is very similar. We find that individuals who lack internet access had more preventable emergency care visits relative to those who had internet access. So in short, our conclusion for AIM-1 is the most vulnerable populations are more likely to visit emergency departments for preventable care, even when we look at individual level data. Turning our attention to AIM-2, here we would like to evaluate the utility of these encounter data for the HAMSA survey. The Census Bureau supports data collection for the National Center for Health Statistics, or NCHS. Our field representatives manually abstract data from patient medical records, and it's a very time-consuming and costly process. The average total case time is around 63 hours per hospital. So our research question was, can these encounter data be used to reduce the amount of HAMSA's data our field representatives presently collect from Utah hospitals, thereby reducing the burden to Utah providers who participate in the survey? And our two findings were encouraging. We found that state emergency encounter records may replace some HAMSA tables and even allow us to create state-level estimates. Specifically, 15 of 27 published HAMSA tables could at least be partially produced, and 7 tables have either the same information or can have even more information if we were to use state-level emergency encounter data. Some of the concepts were similar and were available in Utah data: patient demographics, payer information, reasons for the visit, diagnoses. Some characteristics we did not have: certain hospital level characteristics, mode of arrival, residence types. And we have also determined that additional characteristics could be made available or could even be imputed if we had, in future data delivery, if we had more variables in the data. We also found that only minimal processing was required to prepare the emergency department data to match the HAMSA survey data. Overall, what this project demonstrates is enormous potential. This research was possible because of the unique person-level linkages between the emergency department visit records and the survey data at the U.S. Census Bureau. The partnership between the Census Bureau and the Utah Department of Health highlights the opportunities that individual level record linkages bring by enhancing patient health records with important social determinants of health elements. And with that, I want to thank you for your attention. I look forward to receiving your comments and questions. If you'd like to read more about this project and to look at more findings, you can find it in our research paper at the first link. You can also find more information about the eHealth program and our current projects, and also to explore partnership opportunities by going to the eHealth website. And also, please feel free to contact me at any time, and here's my contact information. Thank you so much.
Thank you, Victoria. I will give everyone a moment to think about questions. Are there any? Norm, I don't see any questions at this time. That's all right. Lots of information, lots of time to think of a question if you're like me. So Victoria, why don't we move to Mary Ann, to our next speaker, and we'll come back to you at the end when I have all three of you on the stage. Allow me to introduce Mary Ann Evans, whose topic is Oregon APAC-Death Certificate Linked Database. Mary Ann, welcome.
My name is Mary Ann Evans, and I'm an analyst with the Oregon Health Authority, and I work on the All Payers, All Claims team. Today, I'm going to share with you a brief presentation about our project linking the All Payers, All Claims data to the Center for Health Statistics Death Certificate data. If you give me just a moment to share my screen. Prior to this project, people who wanted APAC and death certificate linked data had to navigate two separate request and approval processes from the All Payers, All Claims team and from the Center for Health Statistics. APAC and CHS each provided names, dates of birth, and program IDs to a third party, the Oregon Integrated Client Services. ICS then created a crosswalk for each approved project. Requesters received an APAC dataset, a death certificate dataset, and a crosswalk of IDs, and then requesters could link the datasets using the crosswalk. The process was protracted, lengthy, and inefficient for the data requester and for the Oregon Health Authority, including the APAC team, the Center for Health Statistics team, and the Integrated Client Services team. Why link APAC and death certificate data? Linking streamlines the request and approval process for internal and external APAC requesters. The matched APAC death certificate data saves time and resources for requesters and the Oregon Health Authority. The linked dataset supports analyses and research, including health outcomes, health access, equity, continuous enrollment, social determinants of health, and other factors. Collaboration was essential for the success of this project. It took many discussions, meetings, and presentations. APAC has a partnership with the Center for Health Statistics and the Integrated Client Services team. It took support from the Oregon Health Authority leadership and support from the Technical Advisory Group for APAC to have this project come about. A little background about APAC data. We have data from 2010 to current. More than 90% of the Oregon population is included in APAC. APAC includes data from Medicaid, Medicare, and commercial insurers. It includes medical, pharmacy, and dental claims data, has monthly enrollment and eligibility data, detailed provider data, and billed premium data. Standalone, there's very limited death data in APAC. We have hospital discharge status of death, and that's available for all data requesters. There's also diagnosis codes of death that are available for all data requests. However, there are some serious validity issues around those diagnosis codes. A third data source is the Center for Medicare and Medicaid Services reported date of death from the master death file. That data is only available for OHA requesters. APAC has no cause of death or underlying causes of death and has very limited social determinants of health data. Oregon death certificate data includes Oregon residents who died in Oregon or elsewhere, and people who died in Oregon who were not Oregon residents. The death certificate includes the cause of death, underlying causes of death, place of death, tobacco use, and a variety of demographics, including age, gender, race, ethnicity, marital status, education, veteran status, etc. In summary, Oregon death certificates from 2010 to 18 include 313,299 total deaths, or about 33,000 to 37,000 deaths annually. APAC deaths from 2010 to 18 include 278,534 deaths. CMS reported 249,708 of those deaths. An additional 28,826 deaths were counted from hospital discharge status of death. The matching methodology for this project, we use CDC Link Plus and supplemental algorithms. We use first name, last name, date of birth, and date of death when available. There were matching issues with the data. There were just some errors and differences in the data sources. Name changes, including marriage, divorce, and adoption, spelling differences across data sources, and naming conventions. One example of matching issue were the 23,000 Oregon residents in APAC who had a reported date of death from the Centers for Medicare and Medicare Services, but were not able to match them to a death certificate data. They may not have matched because of some of those errors, or they may have been uninsured or not reported or not covered by the insurers who report to APAC. A high-level summary of the MATCH project. Death certificate is available for about 284,000 people in APAC, or about 91% of the Oregon deaths. An additional 23,000 people had a date of death reported by CMS in APAC, but those folks did not have a matching death certificate. An additional 16,000 people in APAC had a discharge status of death, but we were not able to find a death certificate or match it to a CMS date of death. In summary, death information is available for 323,000 people in APAC when you include the death certificate, date of death reported by CMS, and the discharge status of death from hospitals. Linked APAC death certificate data is available by request. The APAC team and the requesters can submit their requests concurrently. Once the APAC team or the Center for Health Statistics team receives the data request, the two agencies will coordinate that request for approval and for building the data set. The information for the request is in the link, and I'm available. That's the conclusion of my presentation, and I'm now available for questions. Thank you.
Thanks, Marianne.
Sure.
We got some late questions for Victoria as you began, so let's give a minute for folks to enter a question. Very interesting. Tell me again, Marianne, when did you begin the linkage? I forgot.
Actually linking it, or began the process to link it?
Let's do both.
It took several years, lots of presentations and work with our partners and others to be granted the permission. And then we had to work it out with the Center for Health Statistics about how sort of the mechanics of doing it. Lots of conversations about, protect health information and confidentiality. Death certificate data in Oregon is more readily available than birth certificate data, or fewer laws that prevent the release or use of that data. So once leadership was on board and everyone was on board, the mechanics of it took far less time than actually getting approval and everyone on board to do it.
Yeah, stakeholder engagement is always takes the longest time. All right, well, thanks. Why don't we put you on hold and bring you back at the end? And I would like to introduce our last speaker, Michelle Hendricks, whose topic is using linked all-payer claims data to evaluate a primary care intervention addressing the opioid crisis. Michelle?
Hi, my name is Michelle Hendricks. I am a senior research scientist at Comagine Health, and today I'll be presenting using linked all-payer claims data to evaluate a primary care intervention addressing the opioid crisis. My goal today is to briefly describe the intervention and study approach, walk through our linkage plan, and talk about challenges we faced implementing the study. This work was funded through a CDC R01 grant, no conflicts of interest to report. The principal investigator is Dr. Michael Fisher at Brigham and Women's Hospital, and this study involves a collaboration of many partners, as you can see here. Clinicians, public health officials, and policymakers have been implementing a wide range of interventions to address the opioid crisis, but evidence on the effectiveness of these approaches is limited due to lack of data sources that measure the most clinically relevant outcomes. So this study is addressing that gap by using voluntary Oregon all-payer claims data linked to public health data sets to evaluate a primary care intervention that helps providers make changes to improve opioid safety. That intervention is called Pinpoint, which is a 15-month intervention that provides practice facilitation and academic detailing to clinics with the goal of improving pain care and patient safety. The intervention implementation is funded by the CDC and is being implemented by the Oregon Rural Practice-Based Research Network. Our study, which is evaluating Pinpoint using administrative data, is to measure the impact of the intervention on risky opioid prescribing among providers, provider referrals to opioid use disorder treatment, and fatal and non-fatal opioid overdose rates among pinpoint provider patients. Our approach is to use multiple data sources to create the prompt data set. The base for this data set will be the Oregon Voluntary All-Payer All-Claims, which is what we will use to identify the provider cohorts and the patients attributed to them. And also we will use it for substance use treatment data. We will also obtain substance use treatment data from the Measure and Outcomes Tracking System, which provides referrals to non-Medicaid publicly funded substance use treatment, which wouldn't typically be in our claims. We'll also obtain fatal opioid overdoses from vital record death certificates. We'll obtain opioid-related inpatient hospitalizations and ED visits from hospital discharge data. We'll get risky opioid prescribing measures from the Prescription Drug Monitoring Program data, which provides dispensed prescriptions for all retail pharmacies in Oregon. We'll use emergency medical services data to assess non-fatal opioid overdoses that may not have made it to a hospital or an ED. This is an exploratory outcome. And then we'll also incorporate implementation details into the data set. Just a note about using the APCD for research. The voluntary APCD is one maintained by Comagine Health and is not the same as the state APCD, which is overseen by OHA. Both OHA and Comagine Health receive nearly identical claims data submissions from payers with some differences, minor differences. The two databases run through two different vendors, and the data processing and data creation is somewhat different as well, although we are working to align those as much as possible. So the APCD, the voluntary APCD that Comagine Health has, contains data for approximately 80% of Oregonians, 100% of Medicaid, 85% of Medicare, 81% of fully insured, and about a quarter of self-insured commercial population. The Oregon Data Collaborative produces the APC and provides quality improvement and utilization measures for data submitters and health organizations. There's also a process by which researchers can use APCD, though we cannot prepare and release research data sets because of our data use agreements. The data must be prepared and analyzed at Comagine Health. Navigating a lot of the statutes around the APCD and also the public health data sets that we link it to was very complex, required a complex methodology that I'll talk about in a moment. The prompt data set is a longitudinal data set, so we'll be looking at measures over time, and it summarizes study outcomes at the provider level. So for instance, we'll be looking at metrics such as the percentage of a provider's patients on a high dose opioid, or the percentage of a provider's patients who experience an opioid overdose. And we'll look at that over time before and after the onset of pinpoint. Data set creation requires probabilistic linkage of patients, even though we aim to be at the provider level for the final data set. Most of the public health data sets and the APCD, of course, are at the patient level. So linkages are occurring at the patient level on name, date of birth, and sex. We use the FastLink R package to do the linkages. And now I'll talk a little bit about the linkage methodology and the steps involved. So the first step is to identify the cohort in the APCD. So as the pinpoint team recruits clinics, they tell us which providers are at those clinics. And then we use the patient provider attribution in the APCD to identify which patients are at those clinics over time. And then we also match those pinpoint providers to control providers and identify the clinic affiliation for those control providers. We do that currently using a claims-based method. And then once we identify patients, all of the patients and all of the providers that are participating, then we can link those patients to a number of data sources, MOTS, EMS, vital records, and Comagine analysts will conduct this step. And then we can also, once we have this enhanced APCD, we can link it to hospital discharge data because Comagine analysts are not allowed to have access to identifiers and hospital discharge data, so we must conduct that linkage at the Oregon Health Authority facility. So that occurs in a separate step. Once we've linked with hospital discharge, the Comagine analyst aggregates the patient level enhanced APCD up to the provider level, calculating those provider level measures over time from all data sets, and links it to the pinpoint implementation data at the provider level. At that point, all the reference data sets, such as vital records, merchant, EMS, MOTS, HDD, all those public health data sets are destroyed to avoid the possibility of re-identification. At this point, we're ready to link to the prescription drug monitoring program. In order to do this, the Comagine analyst shares our patient to provider attribution table, which has all of the patients and providers involved in our study, and that will be given to the Injury Violence Prevention Program at the Oregon Health Authority, who are the data stewards for the PDMP. So when they get the list of providers in the provider lookup table and the patient to provider attribution table, they create masked identifiers for all identifiers, and they retain that master list. And then we will also give them our PCP, our provider level APCD that has the pinpoint data, and they will replace provider identifiers with a masked identifier that they created in the provider lookup table. Finally, IBPP will pull all prescriptions for all providers in the lookup table. They will link the PDMP file to the patient to provider attribution table to replace patient identifiers with masked identifiers that they created. They will also create new masked identifiers for patients who were not in the table, and they will replace DEA numbers in the prescriber ID field with masked identifiers from the provider lookup table. And then in the final step is for them to remove all identifiers from three of these tables and deliver those to Comagine, who will conduct the analysis. So lessons learned in this study, it took us about 1.5 years to get all DUAs approved and finalize a linkage plan. We did get the APCD approved first so we could start the bulk of the coding while we were waiting for additional approvals and waiting for the intervention to add cohorts. But we saw that there is definitely a need to build in enough time to allow for planning and collaboration with data stewards. Developing the linkage plan may be complex, and you may have to go back and forth between data stewards to develop a plan that is adequate, and also leave time for any bureaucratic processes around approving DUAs. We also had some issues around provider to clinic attribution. And this is of course critical to study success in this kind of clinic study. The Oregon Data Collaborative does maintain a provider roster, but we found that it was not extensive enough to cover all of the clinics in pinpoint. And so we ended up doing some primary data collection to supplement that and to make sure that we had accurate provider rosters for the clinics. And then we also needed to develop a solution for attributing providers to clinics for control providers, because we were matching providers to intervention providers to control providers, and we had to identify clinics for those control providers as well. And so for that, we've been using a claims-based method to identify those clinic affiliations. Finally, intervention delays have been a challenge on this study due to a data lag of about 7 to 8 months for the claims in APCD. Ideally, the study would continue well beyond the end of the intervention to allow us to receive and analyze linked data covering through the end of the intervention. But because of COVID delays and additional adding of cohorts related to some of those delays, the end date of the study kept moving, and additional cohorts kept being added, making it not possible to capture the entirety of the intervention for all waves of the intervention during our study period. Thank you very much. That's all I've got for today, but happy to answer any questions.
Thanks, Michelle. Norm has gathered us all again, and lots of questions have come through the chat. So without any further ado, Norm, I'm just going to begin with our first question from Cindy to Victoria. How many states are as ready as Utah in terms of reducing the amount of NHAMC's data?
This is a great question. My honest answer is we don't know. We were so focused on getting this project completed with the Utah data that we've received. Now that it's done, now we are starting to think about what other states have records like Utah Department of Health, how representative it is, across all the states, and actually planning to talk to Norm and his team at NATO to see if this information is already available that we can tap into. Great question.
Another question to you, Victoria. Could you explain more how the Utah ED visits were linked to the ACS data? I had a question similar to that. Can you go into a little more detail?
Absolutely. So we actually rely on the existing data linkage infrastructure that has been around for at least a couple of decades at the Census Bureau. And basically the way it works is every data set that we have at the Census Bureau and all the data that we bring from our partners externally into the Census Bureau, those data sets go through our exact and probabilistic data linkage process. We have what's called the reference file, which primarily consists of Social Security Administration records, but they are also supplemented with decennial census records, survey data, and a bunch of other administrative records data. So you can think of that reference file as kind of being this agglomeration of lots and lots of data sources. And so any data set that comes in, data set would come in identified with personally identifiable information. So it would have social security number, it may have name, date of birth, sex, address, all those different elements that would go through our system that's called Person Verification System, PVS. And once a match is found between an element in the incoming data and the reference file, that record would get assigned our anonymized internal record linkage key, which is called Protected Identification Key, or PIC. And PII elements would be dropped. And so every data set we have at the Census Bureau, whether it's survey or administrative records data, those data sets have PICs. And so when we receive data from Utah Department of Health, we receive the data with social security numbers, with names, with dates of birth, sex, and address. And because of us having SSNs in the data, our match rate, or kind of that PIC rate or PIC assignment rate, was really high. It was actually 95% of the records of the people in the Utah data that we could find internally at the Census Bureaus in that reference file. And so the match rate was really high. Our linkage infrastructure, if we have SSN, it is an exact match. If we do not have SSN, then it has several different modules. If no SSN, then it goes to name, date of birth, address, and those linkages are then probabilistic. So that's roughly kind of how it's done.
Okay, thank you. The next question Jacob has is for Marianne, I believe. Question: how do you use these linked data? Also, is the linkage scheme you created rather specific to only death certificates, or are you thinking about using this linkage scheme elsewhere?
Primary use is to offer the data to data requesters. So in Oregon, you can request the linked data. So that's primarily why we put it together. We have some initial work that we've done for various requesters around it, but pretty limited. We've only had it available for less than a year. So mostly people don't know it's available. So hopefully this and other avenues, we posted on our webpage. So hopefully we get more requests. Another challenge is we changed vendors in the last year. And so we've been working primarily on that new vendor solution, and we haven't integrated this into the new solution at this time. The linking I do, it's not really specific to death certificate. It can be used for linking across any sort of data set. We've used it for finder files and other things as well. Yeah, and we hope our next step is to link birth certificate data. But as I mentioned in my presentation, or mentioned earlier, that there's a different legal hurdles to get through for releasing birth certificate data.
Okay, thank you. Cool. Someone was trying to enter my office and I was stopping it. So we're on stage here. Okay, the next question it's for everyone, for the panel as a whole. Could panelists discuss the 2 to 3 most challenging hurdles, technical, organizational, policy, to the linkage project they faced and how they overcame them? I would add to that list stakeholder engagement. Why don't we start with you, Michelle? We haven't heard from you.
Sure. Yeah, I mean, I mentioned some of the challenges during my presentation, some of the challenges in regards to timeline and delays around COVID and the intervention and data lag. Another big challenge for us has been that provider to clinic attribution. Our initial study was planning to conduct all the analysis at the clinic level, conduct propensity score matching, on clinics, and so we had to change that plan when it became clear that we were not going to have like a reliable provider affiliation for all of those clinics, because we would essentially need all clinics in Oregon, eligible clinics in Oregon, to be able to do something like that. That's why we switched it to a provider level analysis. So that has been challenging, and just sort of how it has modified our analysis plan. And then also we've had to do some primary data collection ourselves to get those provider rosters. I think those 2 things are the biggest challenges, have been the timeline and the provider affiliation.
Mm-hmm. Victoria?
It's really about building partnerships, building trust. The project that I presented on today, it is a voluntary state-federal partnership, and it did take time. It required some persistence and patience, and I'm sure you've all went through the same thing, where you have multiple sets of lawyers involved and data stewards, and we had to have public hearing, and we had to get lots of approvals done in order to receive data, and we needed data to have PII in order for us to conduct our linkages at the Census Bureau. So that took some time. And then, of course, on the other end, we take confidentiality seriously. And so we really had to, once we produced the results had to go in front of our disclosure review board, and we really had to, we have a lot of kind of internal steps to review the paper. So we had statistical review and peer review and fact check and disclosure review. So those things take time, but we're really happy with the result. And one thing I would also note, and that goes back to the first question about other states' data, I don't know yet at this point what kinds of challenges we will have, how standard the data are across states. So that is something for us to look forward to as well.
Great. Marianne?
Yeah, I think I think my colleagues have covered it well, and in the presentation. A lot of it is time and getting buy-in from stakeholders, leadership, and then that partnership across agencies to get it across departments to get the work done.
Yeah. A good question to all. Has anyone tried linking corrections data?
I had a data requester who wanted to link APAC data with Department of Corrections data, and we were prepared to do that. But the Department of Corrections has to provide consent, a memorandum of an interagency agreement, and they were not able to obtain that agreement. So I know we have requesters who are interested, but the challenge is, again, probably protected information, confidentiality.
In that scenario, were you able to get a glimpse of the corrections data at all, at any level? Even a layout?
The layout of the corrections data, there's several publicly available reports. So I know what their data is. So it would have been possible for us to do it had they did. And I wasn't working directly on the agreement. My guess is vulnerable population and releasing that data to researchers, also with a bunch of protected health information, was probably just too much, or they just couldn't figure out how to do that in a way that protected people.
I do know one group who is working with corrections data and Medicaid data. I'm not sure whether they're doing direct linkages between those two data sets, but they are looking at both. Both. But I'm not on the project, so I don't have many details, unfortunately.
Interesting.
But perhaps it can be done.
All right. What challenges have you encountered when attempting to validate the data linkages results? Let's start with you, Marianne.
Yeah, I talked in my presentation. I think it's the same challenges anytime you're linking a data set. The different data sources have different conventions. Maybe collect the data in different ways, store it in different ways, clean it in different ways. And then there's just variation. So each data source has its own type of errors. And so when you're trying to put the two together, it's a challenge that sometimes you can overcome, and sometimes you just are not able to link people because of the differences in the data sources.
Victoria, same question.
For us, we were lucky because we were able to get data with SSNs, and so our match rate was really, really high. I do worry about, as we partner with other states, or we bring in additional data sets, or kind of even just in the future, right? Our reliance on having SSNs and health records is it's changing over time, and so that will impact our match rate. And we know from other studies that the Bureau has done that people, because we rely on Social Security Administration data, we rely on having people be in that data. So people who move a lot, or younger populations, or immigrant populations, we are less likely to find them in our data in general, in survey data and administrative records data. And so that is something that I do worry about as we kind of talk about linkages in the future.
Yeah. Well, then let's change questions and go to Michelle. This is a really important study. Are physicians open to data-based feedback regarding prescribing, for example?
That's a good question. I think, our study has a lot of partners who are very interested in disseminating this information, and, like the Oregon Health Authority is a partner, NARCAD's a partner. And so I think this information will be disseminated in one way or another throughout the state to physicians once we have results. But I do also know that the state of Oregon is doing some work around sending physicians reports. So reports of their that arise from the PDMP, but let them know how they are doing in terms of their risky opioid prescribing in comparison to the rest of their cohort, say in their specialty. And I know that's something that Oregon is working on right now as well.
Michelle, the next question's for you as well. How long did the project take for planning in all 5 steps?
Well, this project started in fall of 2018. We are now in pretty much fall of 2021. So it's taken us most of this time to get everything sort of in place. We're just now starting. So we, it took a long time to get all the DUAs in place, which I think we have all of them in place now. But we also are still waiting because of the intervention, that the data lag issue. We're still kind of waiting to have all of the data that we need in order to have the full cohort, so that we can truly move forward with the linkages. That's one of our challenges with this project, is that we don't get the data. If the project ends, whenever it ends, we get the data 8 months later. So we're still kind of waiting to that point where we can get all of the the patients that would be attributed to the providers in our study up to the date where we want to basically cut it off longitudinally. And so that's taken some time.
Okay. And the next question's for you as well, Michelle. It's a big one. It
Yes.
seems like there were so many moving parts to this intervention strategy internally. How did you address the various components, such as developing a measures and outcomes tracking system within your team? Did you create, there's more to the question, hang on. Did you create different teams internally or work with outside groups? It is very impressive nonetheless. That's from Jacob.
Oh, thank you, Jacob. Well, I'd say it definitely took a lot of persistence. I think we had a initial sort of linkage concept from the proposal. So we've been working closely with OHA, including in the proposal stage. And so I think that really helped. You know, IVPP, who is the data steward for the PDMP, has been really involved in helping us figure out the linkage strategies. And since PDMP is the kind of the more restrictive agency, or has the more restrictive statutes that govern their data, we typically try to work with them first, and so that's been a really important collaboration, to be able to work with them and figure out something that works for them, and then kind of step back and see how it works for everyone else. And then I think the rest of it, I mean, at Comagine Health, I've had to work across departments and across teams to figure out, with this provider affiliation. I work in research, so provider affiliation was not my wheelhouse. And so it's taken a lot. It's been really challenging and interesting to work across different teams to figure out what needs to be done and how we can do it and meet all of our statutory requirements for the linkages.
Thank you. Another question. These are great models for data linkage for all panelists. What considerations would you call out for others looking to do similar work, specifically regarding the generalizability of your models? Yeah, Victoria, why don't we start with you?
So I'll answer it kind of in the way I understood the question, which may not be right. I think about generalizability of health data and kind of how representative data that we can get our hands on, right? And so of course, I work at the Census Bureau, and we do have population level data. And so from that perspective, I feel like there's a lot that we can do to assess generalizability of health records in general. When it comes to kind of this specific study, we did look at things like, if we look at all emergency department patients in the state of Utah, how representative they are in terms of many different characteristics that we can see, we can have on those patients in the ACS data. So how representative they are of the overall population in the state. And we found that, the people who go to emergency department are more vulnerable on many different characteristics relative to the overall population. Probably not surprising, but we do see that in the data. And if we look at kind of how representative those patients relative to the overall U.S. population, we find that they are closer to the overall Utah population than to the overall U.S. population. Again, probably not surprising, but because we do have population level data at the Census Bureau, we can do those kinds of analyses. I'm not sure if I understood the question, but that's kind of how I understood it.
Marianne?
Yeah, I think I was going to say easy, but it won't be easy for other APCDs to link death certificate. I know others already have, and some are farther away from it. Mechanically, it's not that difficult. It's really the partnership and the buy-in and seeing the value both for the agency and for external data requesters. And as we've all said, it just takes a lot of time to get that partnership and that agreement.
Mm-hmm. 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 Michelle?
Yeah, I would say, somebody say if they were wanting to take our linkage diagram and try to implement it in another state, I would say, there'd be a lot of challenges. Every state's a bit different in the way that they view their own statutes regarding all of these data sets and the way that they work together. And so I do, just kind of mirroring what other people have said, is that like the collaboration and building the relationships with the data stewards is really important, I think, to figure out the feasibility of something like this and to have the discussions up front. I would say, before you go take on a project like this, sit down with all of them, work with everybody who will work with you to try to figure out like what is the most viable way to pull this off, given all of the moving parts that are happening.
So I'm going to finish with a question for each of you. Hopefully it's an easy question. At the end of this hard work, and you actually had the data together, linked together, was there one surprise finding that you haven't already mentioned that you saw and you went, oh, that's cool, that you didn't expect, even if you did expect it, but the result was surprising to you? Can you share? Victoria?
I don't think we had a lot of surprises, but it was really good to see that when we have representative data and we can link it to population level data and we can use individual level data, our findings are comparable to what we've been hearing from smaller scale studies or from area level studies. They're comparable in terms of the direction. The magnitudes, of course, we have a bit more precision, of course, given the data that we have. And we were just excited to be able to do this study as a pilot, as an example of what can be done. So I view that as a success, that we demonstrated what can be done. Of course, we can talk about, we presented some associations and we can look into kind of mechanisms and causal pathways and things like that. But the fact that we've created this and we've demonstrated that it's possible, that was a great success.
That's great. Marianne.
A surprise.
Or something that was cool.
Yeah. I was modestly surprised that there were so many death certificates for Oregonians that I was not able to link to the APAC data. In Oregon, we have a fairly small uninsured population because of the Medicaid expansion, and we had that expansion long before the ACA. So I think it's probably more the quality of the data. Not the quality, I should say, what people's proper name is on a death certificate may not match whatever name they used with their insurer or with Medicare or with Medicaid. And so those name differences, we didn't do a lot of probabilistic, that's some quasi, but the confidence is set really high because we don't want to err. I looked at the data quite a bit on hand, the ones that were not able to match, and they're just so far off. There's not really. So that was surprising. But again, I think it's sort of the nature of the data sources.
Sure.
I'm really jealous that, or I should disclose that in Oregon, by law, we are prevented from collecting Social Security data as part of the APCD, and I can't release it and I can't link it because of that. So that presents challenges for linking our data with anything because we have to rely on the names and dates of birth, addresses, gender, other variables that are available in the data set.
Well, we have about 40 seconds. Michelle?
Okay, very quickly. So we don't have findings yet, so no surprising findings, but what has been surprising to me, having worked on this project, doing this provider attribution for the first time, is just, I didn't expect how difficult it was going to be going in. So, it's been great because we've learned so much about it, and we've developed some solutions that I think we can use for other projects. And so it's been really challenging, but actually very fruitful too.
Great. Thank you to everybody who joined us this afternoon to talk about my favorite subject, data linkages. So Norm, I'm going to give it back to you. Thanks again, speakers. Victoria, Mary Ann, Michelle.
Thank you.
Thank you, everyone. We'll see you shortly with our state leadership panel. Bye-bye.